Yeah, thank you, dear colleagues, for the invitation. It's a great pleasure and honor to be part again of this BUS edition 17. This time I'm going to talk about perioperative advanced care planning, which may be a new concept for some of you. Just want to say that also for us it's a new development which we started a few years ago, and it has been a great success, and I'm happy to share our experience with you. So I don't have any financial conflict of interest besides being part in many institutions and organizations, also in our hospital, where we have ethical questions and where we can use and discuss and further develop advanced care planning in the perioperative field. So if we talk about advanced care planning, we should be aware that there are 4 principles in medical ethics which relate to patients. So we should keep the patient's autonomy, we should do them no harm, we should be beneficial to them, and of course we should also be just with regard to our medical resources. So we should basically share whatever we have for equipment, drugs and stuff, medical stuff, and hospital beds, ICU time, and operating theater time among all our patients. So that are the 4 principles which should lead us. And of course, sometimes they are in opposition to each other. And of course, it's not always easy to find the right way. There's hardly any time white or a black, but often it's a shade of gray. So when we discuss shared decision or advanced care planning, we should also discuss shared decision making, which means that all our clinical important decisions we make, we should explain them to the patient, and of course the patient should also be able to decide what we are doing to him, because it's basically his body and his health and his life. And shared decision making, this concept which then goes into perioperative advanced care planning, is important for those patients who are not able to decide anymore because they are mentally incapacitated, because they have maybe dementia, which is less relevant, of course, let's say in the perioperative acute field. But if you think about sedated patients or patients in anesthesia, then it's very relevant, and it's mostly relevant for those patients who are at risk of life, so high-risk surgical patients. So I want to present you a case of an old lady who had presented in our hospital with a complex gynecological cancer. She had also an extended history of abdominal surgeries before. She was multimorbid. She had advanced COPD with long-term oxygen treatment. She was also cardioly sick. Her post-pom score was low. We'll come to that later on, but she was clinically frail with 5 out of 9. And she had also already do not resuscitate, do not escalate order given, but still she requested surgery because she was symptomatic with a gynecological bleeding cancer. So what are we going to do with this lady? Well, first of all, of course, we should follow the beliefs of the patients, but also, of course, good clinical practice. So we can never be pushed to do things which are medically unethical. But of course, everything which is medically reasonable can be done to the patient as long as he agrees about the treatment plan. But of course, we have to know his beliefs and his plans for the rest of the life, and also his wishes. And in order to avoid any misinformation and misunderstanding, and have a good further treatment way, we should discuss this, the present illness, but also therapy options with the patient, and if the patient agrees, also with his relatives. So if we talk about where this advanced care planning comes from, then we have to think that only recently we were able to resuscitate patients from death, and later on, only little more than 30 years ago, we understood that it's not reasonable to resuscitate every patient. And then there was also a polio pandemic back in the 1950s in Copenhagen, where intensive care medicine treatment started. But again, not everybody can survive illness, and that's why palliative care came up, where patients are treated symptomatically at the end of their life, but not for curative reasons, but basically for a terminal sickness. And of course there, the advanced care planning with advanced directives for the patient's best symptom relief and best quality of life at the end of his life, that's where this advanced care planning developed. And only later on, advanced care planning with the advanced care directives came slowly into internal medicine field with cardiac heart failure patients, because also they, similar to patients with oncological disease, die within a few years. And only now, in the last few years, advanced care planning is lately and slowly coming into the perioperative field. So when patients, or let's say when staff is asked, medical staff is asked, and nursing is asked about advanced care planning and the potential benefits, they are very supportive of that, but they say they have little education. And basically, it's so important to help the patient's autonomy in patients who are at high risk of let's say, of losing their life, and when they are not able to communicate anymore. So that's why we need to communicate with them before they may not be able to communicate during surgery or during the intensive care unit, and to fix a plan as good as possible, which is individualized for this patient. And so, as you are aware, if there are patients who are medically very complex, very sick, with doubtable treatment paths, nursing, but also medical staffs, but also relatives are very distressed about how to proceed. There may be different paths even within the team for more or less treatment. So if we can define the therapy option and pathway before the patient falls asleep while he's still fully conscious, that's certainly very helpful. And of course, advanced care planning, if the patient is contactable, let's say after first surgery, because he's waking up, we can of course contact him again, and also adapt the advanced care directive. So it's a very dynamic form of going for the best treatment for the patient. In general speaking, advanced care planning can be done for every patient at every age of life, and they can be ideally counseled, and of course also the relatives can be included, especially in some countries if the patient is not contactable anymore, or has not been contacted before surgery because, for instance, it was an emergency. The next relative can be contacted about the potential or the most likely patient's wishes for a treatment at that time when he was not able to communicate anymore. So where should advanced care planning be used in the perioperative field? So it's mainly in patients, of course, as we said, who have cognitive dysfunctions. Dementia patients are one possibility, but as I said, it's mostly for the patients who are sedated on intensive care, and for the period where they are sedated in intensive care unit. Then, of course, always for high-risk surgery patients, patients who are very sick already before surgery, and of course the highly frail patients. We'll come to that later on. And of course, all of this goes for advanced care planning is relevant not for the minor surgery, but for high-risk surgery. So that's important. And sometimes advanced care planning also in the perioperative field will be about palliative care. Excuse me. So if we talk about advanced care planning, we should also be aware about frailty. Frailty is not related to a certain biological, chronological age. It's more about the biological age, and it's considered a complex medical entity with weakness and fatigue and reduced biological tolerance for recovery after intervention. So frailty is something which involves a lot of our patients, especially when they are older or when they are living in a retirement home, or it's also very frequent in patients who have cancer. And there are even more patients who have a pre-frailty at a certain given age. So this is the clinical frailty scale, which you could and should implement in your clinical practice. And in the scale out of 9, patients are considered to be frail when they reach a score of 5 or higher, because at that point people will be more at risk for problems and they are less biological fit. So as you have seen, frailty is a spectrum of possible limitations of physical fitness, and it's certainly an emerging pandemic because our society is aging rapidly. Here you see, excuse me, here you see that there are more entities or more domains of frailty. So there's the physical frailty of the body. Then, of course, there's also the frailty of mind abilities. And then there's also the domain of social frailty, which means that patients are less able to interact. And at the very end, the functional impairment is very important. There is some systemic comorbidities, some behavioral changes also, and altogether this puts the patient at a higher risk with a major surgical procedure, so when there is an emergency surgery. Here see that again some other domains which come board to frailty, and overall the incidence of complications increases. There's a higher risk of intensive care admission, but also longer stays, also longer hospital stays. There's a higher rate of complications and also a higher rate of mortality. So frailty in the setting of perioperative advanced care planning is very important. There's also the concept of cancer frailty. So basically they have a frailty here from low to high, then there is the cancer burden, and of course if you have a low frailty and a low cancer burden, then you just go for the normal surgery. But with a high frailty and low cancer burden, you can basically still achieve a quite good, with some rehabilitation, maybe also some quite good result with some surgery. It may be suboptimal because the patient is quite frail. If the patient on the other side is very fit, so the frailty is very low, but the cancer burden is quite high, you can go for extensive surgery with some maybe adjunctive therapy, chemotherapy, and then remove the surgery, the cancer, or it may also be already a palliative surgery, but you can still go for a major intervention because the patient is biologically substantially and sufficiently fit. On the other side, if the frailty is high and the cancer burden is high, you will not be able to do an extensive surgery. So it will be the case that smaller surgery, minor surgery, or palliative surgery, or no surgery at all will be the better option for this patient. And this is another interesting concept about independentness. So you see here that this is the line, the dashed line, where the patient is still autonomous. Below the line, he is not autonomous. So with a minor surgery, he will have a little loss of autonomousness, but recover quickly, while with a big surgery and less autonomy, as you see here, he will basically be dependent for a longer time, but still recover above this independence line and be able to live an independent life again. But with a major surgery and then even a second hit because of complications, the patient will probably never recover again to become an independent life. And this is all what advanced care planning is about. So to understand where the patient wants to be after a minor or major surgery, depending on the therapy options, and to explain this to him so that he can choose what he wants. Here you see in this study, very recent, how patients with different scales of clinical frailty fare at baseline, before surgery, then at hospital discharge, and 6 months at follow-up. And you see that patients with low biological fitness, high clinical frailty, they tend to die also to a higher extent. And so when you go further on and you look here at this list with clinical frailty below 5 or 5 and higher, you see that there's also a difference in mortality. And as you see here, the higher the clinical frailty, the lower the chances of survival, or others said, the higher the chances of mortality. This study shows that the median age in Norwegian ICU is 67%. As I said, a chronological age does nothing say about frailty per se or the biological fitness, but gives you an idea that patients are quite old on the intensive care units. And also here, from an international review of different studies, you see that patients aged 80 and above have quite a low chance of survival, or others said a high chance of likelihood of dying within 2 years' time. So again, you have to consider what therapy you want to give and what intensity of therapy you want to give to elderly patients. Again, elderly per se or octogenarians per se does not mean that these patients are frail, but of course the likelihood is higher to some extent. So again, as I mentioned, less therapy, maybe more. There are of course some possibilities to improve the fitness of the patient with a bundle, a perioperative therapy bundle, so pre, intra, post-operatively, which for instance can be found online or with the ERA Society. So this bundle is certainly an option to improve outcome, but again, it does not help alone. Then there's another option you should understand with when you do advanced care planning. The surgeons have often quite a optimistic view on the outcome of the patient. In this case, 10 high volume surgeons for pancreatic cancer were asked about their attitude to advanced care planning. And it's quite well said that there's some tension, as you certainly have experienced, between hope and realism. I would say that for the surgeons, it's mostly about hope. Not only, but certainly more hope, and anesthetists and intensivists to be more on the realistic side. So while all surgeons agree that advanced care planning is important and talking about end-of-life possibilities is important, 70%, so 7 out of 10 said that they had mixed opinions about when to talk about advanced care planning and the possibilities of not being independent again, or even being able to die, or to have an extensive intensive care treatment and never be back in an autonomous life. Because these surgeons don't want to send mixed messages. That is the overall topic. And of course, you have to be aware that there's some surgical buy-in. So basically, when the patient accepts that the surgeon is doing surgery on him, he accepts to go this way. So this is called the surgical buy-in, and then question is not the big thing anymore. So when the surgeons were asked when they will talk about advanced care planning and the possibilities is that things may go wrong, and it's not simply cutting out the tumor and then everything will be good again, will be well again. They said that most will not discuss this with diagnosis, and not before, let's say only half will have discussed it before the first surgery, and only the second half will discuss other options, advanced care planning options, with the recurrence of the cancer, which is quite late, of course, as you can understand, because lots of complications already happen here, and many patients, or some patients, will not survive even up to the recurrence because something will go wrong around the first surgery. So, as I hopefully could show, surgeons have been the last ones to adopt the concept of advanced care planning and palliative care, because they are the great men. So they have their risk of the great man syndrome, because there's the buy-in, they will cut this thing out and then everything is well. And of course there's also the concept of the 30-day outcomes in some countries, where basically surgeons are rated according to the 30 days success rate. So every fatality within 30 days falls back from the time of surgery, falls back to the surgeon, and so they don't want to have patients die within the 30 days, as I mentioned, in some countries because of registry issues. On the other side, most patients, when they have to die, they would like to die at home, but only very few do. And when you ask in the US, the physicians in this study, most would say that when they're terminally ill, they would not like to have any CPR. Yeah, but on the other side, they do it to their patients maybe, and do also advanced treatments, although it's technically possible, but maybe ethically not reasonable anymore. And in this survey in the United Kingdom, in patients on the intensive care unit, only a third of the patients said that they were able to express their wishes for the end of life if it would have to come, as mentioned, in high-risk surgical patients. Although most of them think that it would be important to discuss this also. And the question is about ethical consultation or counseling in intensive care unit. Is there any benefit to this, or does this just increase the rate of fatalities? So in this study, half of the patients received ethical consultation while the other received normal care. And this study showed that with ethics consultation, there was a reduction in hospital days, but also in days in the intensive care unit, and less invasive treatment. But the survival rate in both groups were the same. So most of the physicians and the nurses and the patients with their relatives, they said that ethic consultations, even in intensive care unit, so safe for patients who had no advanced care planning before the first surgery, was very helpful. So in high-risk surgical patients, there seems to be an advantage to discuss complications, and that things may go wrong, and that therapy may have to be adapted early. It's important. So this should be an individual plan to be discussed with the patient and the family or the next to kin. So I would like to give you a good practice example as we developed this over the last, I would say, 5 to 6 years in our hospital in Austria. So in the anesthetic clinic, we have a preoperative filter for our elective patients. So we have only this 15-minute slot. So for major surgery, when there's a post-bomb score, I will talk about that soon, of 30-50%, so 1 year mortality score basically with a certain type of surgery and a clinical frailty scale of 5 or higher. Then we'll have we have a certain pathway. Again, this is the patient with the gynecological cancer from before, with the DNR and DNA. This is the filter we apply to this patient, and that's where the numbers come from. So the post-bomb score can be accessed online. It's a 1 year mortality score with a certain type of surgery, multivariate score for certain patient factors. And as mentioned, with 35-50% plus, we get the patient out for a special clinic. Same for the revised cardiac risk index of Lee. If it is increased, then with 30-day mortality score, then also some red flags go up. In our patient data management system, we have a known icon where we can access this course. So it's very easy for the colleagues in the anesthetic clinic to access this course and to document them. So when this course go up, we get them out to an interdisciplinary discussion. First we would discuss this with the surgeon, the internal medicine specialist, and the anesthetist, all the therapy options, and then we would explain them to the patients, giving also the numbers from this course I showed you, and therefore saying, okay, with the major surgery you have a 90% chance of not surviving this year, while with minor surgery it's only 5% or 10%, or there may be no surgery. That is certainly a good option. And so this is how we show them, the patients, the different possibilities, and giving also different numbers for 1 year survival. And that of course helps the surgeon to understand where we are, but also the patients and the relatives. And it's not the only, yes, we cut this lump out and then you can go home. And there's an increasing number of high-risk surgical patients. And you have to be aware that you don't have to do this to many patients, because most high-risk surgical patients and their fatalities, let's say after surgery, they are limited to a small subpopulation of patients with major surgery and patients with major emergency surgery. So this is the population you have to focus on top. But I'm talking about elective and not the emergency medical patients at the moment. So ideally, you would like to have this give the best and the worst scenario to the patient, and then he can also decide. And you have to do this, of course, according to national laws. You will discuss about the benefits and the risks, the alternatives, or doing also nothing with the certain therapy options. For this patient, we decided then to do surgery, and but she had a DNR and a DNA. But we said, okay, would we do any CPR on this patient? And we said yes, and this is according to this paper, which recommends if a cardiac arrest happens because it was triggered by the team, the medical team, then CPR measures should be set. This could be pharmacological CPR measures, not necessarily mechanical chest compression. But if it is spontaneously cardiac arrest from personal patient, whatever event, then you may consider not to perform CPR. Sometimes patients come to the intensive care unit without any advanced care planning because they may end up on the intensive care unit on weekends or during night shifts, where ACP, or because of an emergency, and also during the day where ACP preoperatively was not possible. So what are we doing there? Well, in this case, it's important to do some ethical counseling on intensive care unit, as I showed you before. In our case, our lady had a bowel dehiscence. So we discussed, should we do any reintervention? Should we do, how much therapy should we do? Because this was not absolutely clear in this case, we had to do some ethical counseling. As you may, as I mentioned, also do with some patients firsthand on intensive care unit, if it was not defined in advanced care planning concept before. So in our case, we decided for intervention. She was also readmitted to the intensive care unit, and she completed her recovery and went then to the rehabilitation outside of our hospital. So where are we going from here? We are certainly going to develop some national guidelines, and that's the plan for now. And we are also in contact with the EDAIC, the European Society of Anesthesiology and Intensive Care, to develop some European guidelines based on what I showed you so far. So overall, I hope I could make the point that preoperative advanced care planning is an important concept for high-risk surgical patients to individualize the therapy, because less is more in high-risk surgical patients, can be more, And advanced care planning is a win-win situation for the patients and relatives on one side and the medical and nursing staff on the other side. You get also better use of your resources in the hospital. Use numbers. Therefore, use scores to get numbers. Keep it simple and adapt advanced care planning to the possibilities and the needs in your hospital. So thank you very much for your attention. I hope you liked it, and I hope you can use advanced care planning in your area. And if you have any questions, please do not hesitate to come back to me. Thank you.